Today we have the pleasure of hosting Dr. Cespedes for a talk on human papillomavirus in women. Dr. Cespedes is an associate professor of medicine at the Icahn School of Medicine in Mount Sinai in the Division of Infectious Diseases. Dr. Cespedes received her undergraduate degree from Johns Hopkins University and her medical degree from the Mount Sinai School of Medicine. She completed her residency in internal medicine at New York Presbyterian Hospital, Cornell, and her infectious disease fellowship at New York University. Dr. Cespedes is currently the protocol vice chair of 2 AIDS clinical trial group studies designed to evaluate the efficacy and immunogenicity of the preventative HPV vaccine in HIV infected men and women. Her published work includes a Genomewide association study of cervical dysplasia in HIV infected women, articles on HIV-associated metabolic syndrome, cardiovascular disease, and the misconceptions of HIV risk in minority populations. She's also the co-director of ID Division's Clinical and Translational Research Center at Mount Sinai and the clinical research site leader of St. Louis Roosevelt Stanley's Clinic. Nationally, Dr. Cespedes is the chair of the ACTG's Underrepresented Populations Committee and a member of the ACTG Executive Committee. She's a member of the HIV Medical Association and the Infectious Disease Society of America. Please join me in welcoming Dr. Cespedes.
Good job. Good morning, everyone. Pull up my slides. So while we're getting this together, so my talk today is going to be on HIV-associated HPV disease. So worldwide, HPV is not as common. There we go. So let me move forward. So I'm really going to talk a little bit, I'm going to do a little bit of a review about the HPV genome and pathogenesis. When Dr. Geiser was here 2 weeks ago, he did a brief talk, but I actually think for me it's actually helpful to understand some of the mechanisms of disease. I'm going to speak mostly on the quadrivalent HPV vaccine experience in HIV-infected populations with a focus on HIV-infected women, and talk a little bit about my work where I actually did a genetic analysis looking to see if I can find any reasons for predisposition in certain populations. And lastly, I'm actually going to do a brief presentation on some work that we've done with Dr. Geiser and the Jack Martin Clinic with our anal cancer screening program that's been in place here for the past 5 years. So HPV is a non-enveloped, double-stranded DNA virus, and the way I explain it to patients, people, we are divided up in races, but viruses, we actually divide them up in types. And HPV now, actually, every couple of years we increase the number, actually has over 150 types, but the ones that we're concerned with are the ones that hit below the belt. So about 40 of these types can actually cause genital disease, and about half of these are actually oncogenic, cancer-causing. So when most people hear HPV, they think of only warts. So genital warts are caused primarily by types 6 and 11, which cause about 90% of genital warts. But in terms of oncogenic potential, the cancer-causing types, 16 and 18 cause about 70% of cervical cancer in this part of the world, about 65 worldwide. And the next 5 types that you see listed there account for another 10% of all cervical disease. Besides cervical disease, HPV is actually responsible or been associated with about 70% of anal cancers and human respiratory papillomatosis. It's actually a very severe disease, usually seen in kids and sometimes older adults and men, and usually transmitted through passage through the vaginal canal during birth. This is actually helpful for some of the way that HPV actually causes cancer. So the genome of HPV, usually anywhere from 8 to 9 genes, important genes. The E genes are the early genes, the early transcribed genes. The E6 and E7 are the most important for why and how HPV causes cancer. The late genes, L1 and L2, are actually what form the outer coat, shell, or capsid. And L1 is important for how the vaccine works. Just a little bit more on E6 and E7. The way I think of it is that E6 actually helps make the cell immortal, and E7 helps keep it replicating. So E6 inhibits P53, a big cancer promoter or cancer gene, and really makes it immortal, so promotes the loss of cell cycle control. E7 actually prevents the cell from repairing itself or cutting E6 and E7 out and preventing this control mechanism, overdrive, to be prevented. So in this schematic, we really talk about going from clearing HPV to actually why some people actually go on to actually develop cancer. So what we have known is actually that HPV, for the most part, is ubiquitous. So if you actually took blood for most of us, most of the studies are done in women, about 85 to 90% of women actually have serological proof that they've actually been infected with HPV, some of these high risks as well, but may have never developed disease. So for the most part, HPV infection is a transient disease. Most people clear it in about a year or two. It's really when it goes on to persist that it can go on to turn into cancer, and usually we'll start to see changes on cervical pap when the virus has been there for about 3 to 5 years, and actually invasive cancer usually is on the range of 8 to 10 years. This is just another schematic that I like the way that it explains it. So what HPV looks for is little micro tears or interruptions in the tight junctions between the cells, and the virus particles that actually are, here's the lumen, can actually go down and infect the basal cell layer, which is actually responsible for making these flat cells higher up. As the nucleus becomes infected, it actually turns on and actually goes on to continue to create cells that can continue to differentiate. When I do a pap smear, I'm actually trying to scrape off cells on this top layer and looking for any cells that are indicative or have these big, huge, wide, almost clear regions around the nucleus that are indicative of HPV infection. But what I really want to do is actually get to you before you get to invasive disease, once it's broken through the basement membrane. And these are the progressive stages. It really depends on how deep these levels of abnormal cells go into closer to the lumen. So to talk a little bit about the vaccine, so the quadrivalent vaccine, the brand name is Gardasil, actually became commercially available in 2006. And really what we've seen, remember as I mentioned before, the majority of HPV infections are transient. The goal of the vaccine is to actually have you have antibodies already on board or stored, waiting for your plasma cells and B cells to make antibody quickly. So should it become infected with the real virus, it can actually help you clear the virus quickly. Most of our information about the duration of infection and how long it takes to clear is out of this famous study where they actually did cervical lavages on young college-age women, presumably before the age of sexual debut, and serially tested them every 6 months and found that the vast majority cleared the HPV type that they had at the beginning within 2 years. So the new news is most of us are familiar with the quadrivalent vaccine. The quadrivalent vaccine actually helps you make antibodies toward HPV types 6 and 11. So remember, those are the genital wart types, and 16 and 18. So the new news for some of you who may not know is that the same company is actually now licensed and is now FDA approved nonavalent vaccine that includes those original types and the next 5 big players in cervical cancer. So remember I said that these two are responsible for about 65 to 70% of cervical cancers in this section of the world. It's slightly different in sub-Saharan Africa and India, but not by much. But these next 5 account for another 10% of cervical disease. The Advisory Committee on Immunization Practices actually in December now recommends you can be vaccinated with either or. So what it is actually a purified virus. So we actually infected the Saccharomyces yeast, and now it actually makes the L1 capsid proteins, these pentamers that actually auto-assemble and essentially form an empty shell. So actually the way I explained it to a patient yesterday, and she was like, do I need this vaccine? I was like, you're 26, I can give it to you. And she goes, well, will I get infected? So the way I explain it to patients is it's just the empty shell. So think of it as just the coat, but no DNA, so no genetic information. And what we want your body to do is recognize this empty shell as quickly as possible, so you cannot get any infection from it. The drawback is that it is type specific, so you're not expected to make antibodies against any of the other types if you use the quadrivalent vaccine, and same for the nonavalent vaccine. And this data was really pretty impressive. It was tested in over 20,000 young girls aged 16 to 26. Randomized controlled trial, so 20,000 subject trial is incredibly large. They followed them for over 3 years, and it was 100% protective in preventing cervical disease from types 16 and 18. They extrapolated, we can actually, it's recommended to give the vaccine starting at age 11, but they extrapolated, because remember, we're not doing PAPs and cervical exams on girls that young. But what they've done is immunogenicity bridging studies. So they actually saw that these young girls from age 9 to 15 make the same level of immunity that they saw in the 16 to 26-year-olds, and then extrapolate that. It should be just as efficacious. And similar data on the nonavalent vaccine. So this is just a schematic to actually help you understand what's happening here. So you'll have these virus-like particles with just the L1 capsid proteins. Antigen-presenting cells actually prime B cells, and plasma cells make antibodies, so when the true virus is encountered, it actually has difficulty actually getting in and easier to be cleared. So important points, I mentioned already that we've done the immunogenicity bridging studies, so even though we're not doing PAPs or figuring out how or which virus they actually may have already been exposed to, we know that they make the same levels of immunity, the same levels of antibody as expected in the older populations. I think what people forget most often is that originally it wasn't FDA approved for boys and young men, but about 3 years, 4 years after it was introduced, it is now recommended that both girls and boys be vaccinated in middle school around age 11 to 13, and we're essentially doing catch-up for the slightly older group that didn't have the vaccine available when they were younger. One of the things that I always make sure I do, whether or not someone is MSM or not, is that I offer it to all men. People can actually receive it if they're over that age, but they just have to pay out of pocket. They would not be covered over insurance. The other thing to remember that these are not therapeutic vaccines. So a preventative vaccine is to help actually prevent you from actually getting established infection. A therapeutic vaccine would actually be thought to help you after you've already had disease. The interesting things are that there are actually people in many, many places all over the world have actually tried to use it and actually had some promising results using this as a therapeutic vaccine. There's one case in a large group of women who had low-grade cervical lesions in Africa, but more often it's actually been used in respiratory papillomatosis, actually, as adjunctive therapy. And what they've seen that they can actually increase the length of time before recurrent papillomas come and need to be lasered or treated again. All right? And this actually came up, one of my patients asked about whether or not it contains mercury, and mercury to be been associated or blamed for some causes of autism, where people thought that some vaccines were related to mercury. This vaccine does not use mercury as an adjuvant. So now I'm going to talk a little bit more about the vaccine experience in HIV-infected populations. So as you can imagine, HPV, since you need a good immune system to actually clear it, oftentimes we've actually seen that it's been a larger burden in both HIV-infected men and women. So there's a higher prevalence compared to age, race, and behavioral matched HIV-negative controls. And cervical cancer actually became an AIDS-defining illness in the early 90s. And while we see very few increase in AIDS-defining malignancies such as KS or even Hodgkin's lymphoma, there's actually been very little reduction in HPV disease since the introduction of good therapy to fight HIV. There's a huge cohort called the WISE cohort. It's actually a cohort that's been going on for just shy of 20 years now, and it's about 6,000 high-risk women. The vast majority have HIV, but about a quarter are actually HIV negative, but have the same risk factors, or even an HIV-infected partner, or former sex work in exchange for money, or IV drug use, or things that are really associated with acquiring HIV. And they've essentially followed them for all these years and done cervical lavages and stored blood and actually genetic-based sample storage for the past 20 years. And what we've actually seen is that HIV-infected women are more likely to have evidence of multiple HPV genotypes that stay around longer than those expected 2 years. The other caveat is when we do find HIV-infected women with disease, they're actually more likely to actually have it recur even after a standard treatment with colposcopy LEAP or a deep cone biopsy. So one of the original studies that was done by a colleague of mine, Tim Wilkin, over at Cornell. And this really just wanted to say, since HPV is more prevalent in HIV-infected populations, will the vaccine work in our population? Essentially, they didn't check to see for many years for efficacy. They wanted to see, similar to what we did for those young girls, did these HIV-infected men make the same amount of immunity after vaccination as expected? This cohort actually used people who were actually a little older than the recommended age of 26, but all of these men were HIV well controlled, so undetectable viral loads and relatively high CD4 counts. And what they found is that 95 to 100% of these men made vaccine-specific HPV type antibodies as expected 1 month after the third vaccination. And we've seen it used actually in pediatric studies that were actually looking at children who were either infected at birth or early on in a young age, and we've seen similar rates of immunogenicity in that population. So a group of us said actually this is more of a problem or more of a documented problem in HIV-infected women. So what we did actually is look not just how well they made immunity, but actually to see whether or not it made a difference if they actually were not undetectable, so actually had active HIV virus that could be detected, and at all CD4 counts. So there's some vaccines that we do not give to HIV-infected people with low immunity. There's data that it actually makes a difference whether you're undetectable or not, and sometimes it can make a difference whether or not you have a CD4 count above 200. So oftentimes people think if they have a low CD4 count, they're not going to make enough antibodies, why bother? That actually turns out not to be true for hepatitis B vaccination. It actually is more important whether or not you have a viral load above or below 10,000 copies to see if someone would actually make adequate immunity. So we chose the cutoff of 10,000 copies to stratify all of our subjects, and we looked at CD4 counts even below 200 to above 500. And if you want to take a quick look below, I want you to actually take a look at what's considered enough immunity. So this is actually mirrored after what we see in natural immunity, the amounts that you get for each type. So on the range of units of about 20 or so. So we enrolled just over 300 women and evenly dispersed among all three strata. Strata A was the highest CD4 count, above 350. B was that middle of the road, above 200 to 350. And stratum C was our lower CD4 count cutoff. Stratum A was a little higher. We actually modified the study midway when we realized that there was actually no difference between viral load count. It turns out that it was just as efficacious regardless of your HIV viral load. The majority of women were actually African American and Hispanic, which actually mirrors the HIV epidemic here in the States. And the majority of them, a fraction of them, were not on antiretrovirals at the time. So in terms of baseline seropositivity, so one of the reasons that we chose the age actually was age 13 up to age 45. We chose 13 because one of the pediatric studies actually had the cutoff of 13. We wanted to make sure none of our peds kids between 13 and 18 didn't get the opportunity to get the vaccine. But one of the first critiques was like, why are you giving this to older women up to age 45? Isn't the rationale to give it to people before they start having sex, before they're actually exposed to these HPV types? It turns out that people still have sex in their 30s and 40s, and we actually had data from the WISE cohort that people still continue to acquire it. We actually had data from Merck as well that they had done immunogenicity studies from the ages of 26 to 45. So we actually had data to compare and contrast to that had not been published at the time when we designed the study. So this was just the baseline seropositivity. Even though we obtained the blood and did these studies, we actually didn't want people to actually do that in clinical practice, but we just wanted to know for ourselves. We didn't want people to have to get a test to see whether or not you've already been exposed to 16 or 18 and whether or not you would benefit, but we just wanted to know the prevalence ourselves. And as you can see, for the more important oncogenic types, only about a third had seropositive to 16, and a lower fraction to 18. The other caveat to this is that sometimes seropositivity, if the absence of it does not mean that you're not immune. So what we do see sometimes is what's called an amnestic response, meaning that your detectable level of antibodies is low, but should you be introduced or vaccinated a fourth time, one more dose, you see an extraordinarily high burst, more than expected, with antibody response, meaning that your B cells and plasma cells are just laying low, waiting to attack, but may not be able to be detected. So one of the, my slide sheet, there we go. So one of the other things we did said, would there be a benefit? We wanted to see how many women had actually already been exposed to all four types and therefore would be less likely to receive any benefit. And as you can see here, 96% of the women would actually get a benefit from at least one type. But more importantly, a large portion of them had no detectable antibody to any of the types. So after week 28, 1 month after the third vaccine, what we did see is that for the majority, greater than 90% of women actually made adequate antibody response. There's a slightly lower response in the women with the lowest CD4 count here in orange. And more strikingly, you can tell that there was a lower antibody response across all CD4 stratum with HPV type 18. This is actually not unexpected. This is what we've seen consistently, even in HIV negative populations and in the smaller men study that I mentioned earlier. The other thing I like to show is the actual level, the units of immunogenicity. So if you remember that first slide, I told you that cutoff for what natural immunity confers is around 20 units or millimerc units. And as you can see here, we're getting antibody levels in the 200, so the 10 to sometimes 50 times greater fold immunogenicity response at week 28. We will soon be coming out shortly with data looking at the duration of immunity over a full year. So this study, 5240 overall, the seroconversion rates were actually quite high 1 month after the third vaccine, slightly lower for women with lower CD4 counts, but still a truly great response. It was found to be safe. We had no major adverse events. There was one lady who had who died, but it was from a lymphoma or a brain mass issue that was not thought to be related to vaccination. And shortly we'll be coming out with data on the durability of the response over 1 year. So I actually did want to take a moment to actually talk about some of the experimental data on HPV therapeutic vaccines. Though these vaccines are thought to help you after you've already been diagnosed with disease. Just to recall that expression of E6 and E7 is needed to actually progress to cancer. And what you really want is cell-mediated immune responses to play a role in actually kind of gobbling up these infected cells and viruses. And we've actually seen some of that data work in actually vaccine data and studies that's used in cancer vaccines. So really the goal of therapeutic vaccines is to generate cell-mediated immune responses. And for the most part, these cell-mediated responses are actually not type-specific. So we can actually, if we can actually get a vector that can contain E6 and E7 and have it work, it is thought to be able to actually protect you from whatever type you may be infected with. For the most part, the most research has actually been done with protein and peptide-based HPV vaccines, where they actually fuse E6 or E7 with an adjuvant or a peptide or protein. And in some instances, there's actually some very, very small data sets looking at dendritic cell and actually even viral and bacterial vector. There was a L-cytogenase bacterial vector-based vaccine. But these are mostly small phase 1 and phase 2 trials. The vast majority of them are actually more than 10 years out. We haven't seen phase 3, or at least even 2B. So I suspect that these probably are not going to go too far or would be cost prohibitive to continue to be developed. There's very limited data in these vaccines, these therapeutic vaccines in HIV infected populations, but there are 2 small trials that actually used a heat shock protein fused with E7. He shot protein from Mycobacterium bovis as the vector to actually induce responses. So these two small studies, I'll just spend a moment on them, actually looked for anal disease or therapeutic use for anal disease in HIV-infected men. Both were in men. What they saw is that only about 70% of them, actually in this original study, actually did produce interferon gamma responses that actually are indicative of cell-mediated responses. This smaller study was actually done by Joel Palevsky out in San Francisco, and actually looked at men who had high-grade anal disease, about 15 of them, and injected them with this therapeutic vaccine. And essentially it was, a little bit disappointing. So essentially there was no response, null response in about 2/3, and either complete or partial regression in about 1/3, but none had progressive disease. And what's more fascinating is that this is such an incredibly hard disease and hard area to treat that what you do see more commonly is progressive disease. So even the fact that there is some stable disease may actually be a step in the right direction. I'm going to talk a little bit about my work that I did for looking for actually candidate markers for cervical dysplasia. As you recall, I remember I said that HPV is ubiquitous. So if all of us have been infected, why do only some people get so sick? So I spoke about this again. What's actually interesting when you look at cervical cancer data on the registries, here in the States, both Hispanic and African American women have comparable incidence rates of cervical cancer. So, it's gone down dramatically since the introduction of routine Pap screening in the 50s and 60s. But despite the incidence rates being fair, African American women still had the highest death rates remarkably. And they've actually looked to see is it whether or not it's insurance related or socioeconomic or just late presentation of disease. And it doesn't seem to account essentially for all the difference. So I spoke a little bit about this already, that we tend to see it, definitely cervical cancer, more in HIV-infected women. But compared to their HIV-negative controls, the prevalence is 64%, compared to less than 1/3 in HIV-negative women. And there's a 5-fold increase of cervical cancer with HIV or AIDS. So one of the first things I did and looked at, and I was like, well, we actually have a lot of information, or a lot of data has been presented on HLA associations and its association with other cancers. Has there ever been any work looking at HLA with cervical cancer risk? And this was a good review from slightly more than 10 years out now, but it actually had some of the original studies, about 30 studies here, looking at, once the PCR and burgeoning technology was able to better take a look at HLA subtypes. So HLA is our human leukocyte antigens that help determine how well and how efficiently we can make some antibodies. We saw that the data was all over the place. Sometimes certain HLAs came up in certain populations, and some didn't, yes, no, plus, minus. But what was even more striking to me, I always think about, would this apply to the patients that I see here in the States, here at Bellevue, and here at Mount Sinai? And the answer is essentially always no. So what I bolded in red was actually the few studies that included either African American or Hispanic women. This small study actually was done in Senegal. And they usually take a look at a handful of cases on the order of about 200 to 300, and maybe 2 or 3 to 1 matched case controls. But essentially the data in African American or women of color was scant. So then I worked with one of the geneticists, and I actually said, is there a better way? Is there a better HLA testing I can do? And he's, well, why don't you look at things besides HLA, and why don't we just take a look at all their genes and see if anything comes up? So I'm going to do a brief 1-minute primer on genome-wide association studies. So essentially, instead of just looking at one specific gene or antigen or HLA factor, what a genome-wide association study wants to do is actually look at all the genes between your group of cases and compare that to all the genes in your group of controls and see what pops up and then work backwards. If you find anything significant, you kind of find out the name of that gene and what that gene does and work backwards. So GWAS has actually now become available since we've done the human HapMap, so this has been only about 10 years out now. But GWAS has actually identified SNPs, so SNPs are single nucleotide polymorphisms, slight changes in your genes that would change an amino acid. That is really one of the most famous ones, has actually been picking up a gene associated with macular degeneration. There's been some studies actually looking at associations with diabetes and actually risk of HIV progression. So this study is actually called the HIV controller study. So this came out in 2010. And I put the graphic up here to actually help explain to you what is called a Manhattan plot. So a Manhattan plot actually lays out all the genes or all the differences between the genes, between your cases and controls, and actually sees if there's a big difference or an outlier in a set of genes or gene region. It's called a Manhattan plot because when things are less significant, it actually looks like the Manhattan skyline with buildings and dots and dashes. This study actually showed one of the most significant GWASs to date. This study actually looked at, is there a genetic difference between people who are what's called elite controllers? People who have HIV, we can document that they have HIV, but they are undetectable without the use of antiretrovirals. So they have an undetectable viral load without needing HIV medicine. So we had about 1,000 of these patients worldwide. That group came to us and actually said, the AIDS clinical trials group, we know that you guys have stored blood and genetic samples from several thousand HIVers who progress normally. Can we use them and do genetic testing for them to be our controls? So the AIDS clinical trials group donated about 2,200, I believe, or about 2,000 HIV normal progressors. And all of these people had their genomes mapped and tested. And then they saw that this was the difference between the elite controllers and not. So I said, aha, since I'm in the ACTG and they've already have data on 2,000 HIVers, can I just look at some of the women and some of that data? It turns out some of the women who agreed to get genetic testing or have these stored samples also had GYN screening or update forms biannually for the last 10 years or so. So I said, well, you know, it's not ideal because I'm not doing the testing myself, but can I look and match it with their cervical and cervical cancer history files and compare that to the genetic data that we already had on file? So the genetic data that we already had completed by the guys at Harvard actually linked to the GYN history and semi-annual GYN exams for my HIV-infected women. So what we did is actually, after quality control, we actually looked at about 600,000 polymorphisms for all of those genes. And the significance level was, you know, it's a predetermined significance levels that we've seen in other GWAS studies. And then I had to learn some fancy computer programs and figure out what they were talking about. So from that huge data set of about 2,000 people, there were just under 500 HIV-infected women who had all their genome data done. About 350 of them actually had recorded GYN data, either from GYN studies or from the semi-annual form through the ACTG. And essentially, there were a few that either had some inflammation or ascus that on repeat, we couldn't quite bear out what level of dysplasia, so I decided to not include those. But essentially, we had 133 women with normal PAPs continuously out of these 350, and just under 100 with cervical dysplasia, and 20 with high-grade lesions or cervical cancer. So just on routine demographics, the average age was about age 40. Again, the vast majority of these women were African American, just about 56%, and another 20% or so Hispanic. Most of them had actually had AIDS definitions, with nadir CD4 being less than 200. And at the time of entry into these studies, some of these were naive studies, so people who had not been treated for their HIV as yet, their baseline HIV viral load on entry was about 73,000. So when I compared people with normal PAPs with any level of dysplasia and women with high-grade dysplasia, the only things that came up significant was a history of substance abuse for women who had high-grade disease compared to normals. And if you look down here, women with a history of trichomonas. I'm going to touch base on that a little bit later. Actually, there's been several studies that has actually linked trichomonas with the development of cervical disease. And it turns out the mechanism of action is that trichomonas can actually interfere with the tight junctions between cells that would actually facilitate HPV getting access to the columnar cells. So if we looked at both univariate and multivariate analysis, you know, as a student, all I do is I look in the p-value columns, and essentially the only thing that came up maybe significant was trichomonas, but actually when you do multivariate analysis, it all kind of dwindles away. You know, you would think some of the things that may be important that was not collected on the data sheets were age of sexual debut, how old was the woman when she first started having sex, number of sexual partners, and things like that that we didn't have information on. So when I did my GWAS, so what we first did is actually looked between women who were completely normal and women who had any level of dysplasia, low grade or high grade, and there was a disappointing wah, wah, because there was no association. So then I said, well, let me try. It's like, you know, maybe we can look between high-grade disease. And it's pretty faint for the back of the room, but the level of significance is this slight light pink line that's across the top here, here, and here. So the first data set actually is looking for women of all races, comparing those who are completely normal with the ones who had high-grade lesions or cancer, and there are three, what's called reference sequence that popped up, but which actually correlated to 2 genes. This section, so I spoke to the geneticists at Harvard, they're like, this is okay, but race actually plays a big factor in genetic predisposition and differences. Can you look at just the African Americans because that was the largest subset of your data set? So I said, okay. So I looked at African Americans alone and actually had a few more genes that were above this light pink line. And I said, well, this is even better, isn't it? And they said, well, your data set is so small that it probably doesn't mean anything anyway. But why don't you take a look at these African American women with cancer and high-grade lesions and actually compare it to their 3 closest genetic matches, because you could figure out who's essentially their sister, not their twin exactly, but who would be their study sister by genetics. And if you take all those cases and match them up with their 3 closest genetic sisters, you still get 1 gene that falls right on that significance line. So this is a table of all those genes that came up significant. I'm going to move slightly. So again, remember this is between all the women with high-grade lesions and subsets with African Americans alone compared to other African Americans or their 3 closest genetic matches. So because I don't know the names of the genes and all they do so well, hold on, I highlighted them for you. So in the subset that was limited to all women, we actually see this PRKCE. It's actually a kinase gene. It's actually an oncoprotein that disrupts the reactivation of tumor suppression, PRB, and promotes transcription of the c-Myc oncogene, so this one. Because essentially what you want to do is, like, do any of these genes make sense in terms of cancer or infection? You know, is this, you know, does this gene, you know, determine eye color, or does it have something to do with cancer? So I actually went through all of these. You actually have to go through the human hap map. You have to find which gene it lies closest to. You actually see the difference, and actually this is the amino acid or the SNP that's changed. For you guys, actually, you know, these are the true p-values, but since we did over 1 million tests, kind of look at the Bonferroni, and that brings it back to the 0.05 p-value that we're used to looking at. And this is actually called the mean allele frequency, that we can actually separate them out by race. So the hap map, you know, when I think it's on Channel 13, or you can see like what tribe in Africa am I from, or where is my family from, or, you know, am I Sephardic or Ashkenazi, or where did I do all my lineage from? So they actually have reference pools of people who are considered either the most white, the most Asian, and the most African, essentially. And you can see how frequent this gene is in those populations. So this is considered the Caucasian or European population, and this is from a group in Yoruba, I think Nigeria, which is considered the African population. So this one, I remember I said that this is an oncogene promoter. The next one, HECW2, actually enhances the activation of transcription by a gene that actually encodes for p53, which remember we said was already important for HPV E6. GFB1 up here, which actually had our highest association, is actually a guanine nucleotide exchange factor that regulates recruitment of proteins by mediating ADP ribosylation factor. I was like, I don't know what all this stuff is, right? But it actually turns out that this, what it interferes with is actually important, or actually crucial for hepatitis C, Coxsackie, and poliovirus replication. So I was like, oh, that might be important, right? This is a resident Golgi gene. It turns out that this one, Golima, or GOLIM4, is actually also a resident Golgi gene. And this one's actually important for transport of cargo and protein products down the endoplasmic reticulum. The next two that I thought were interesting or had some associations with cancer and cancer development is actually this one with far too many letters. So this SH3 gene is actually involved with invasiveness of some cancer cells. And this ATF3 is actually involved in cellular stress response that actually can affect apoptosis. So remember when I compared either some of those clinical factors to see if there's any significance, there is much higher significance with these genetic factors, or these are the reference sequence based on the genome-wide analysis. But when you do multivariate analysis, essentially some of these impossible odds ratios, infinity, just doesn't make sense. But it's really an artifact with a small sample size. Again, so to really make sure that this made sense, we would have to do it in a much larger sample size. So just quickly, because I thought this was interesting, the geneticist I work with, Dr. Oster, actually said, well, why don't we look at some of their racial makeup as well? Sometimes you can actually see if there's a predisposition to disease or even response to treatment by someone's genetic ancestry. Particularly easy or more important to do in African Americans, because African Americans have only been here for about 20 generations or so. So we can actually tell, and they've actually quite a lot of intermixing. You can actually tell if we do find a risk allele or a risk gene, if it's more or less likely if they've inherited it from essentially their African ancestors or their European ancestors. So figure A actually looks at all of the cases of any dysplasia compared with their genetic controls. So the African Americans here are in this green. So remember I talked about those reference sequences from the human HapMap. This pool of people is considered the standard mark for the Asian population. This red over here is a European population. It actually turns out that it's a group of about 150 people from Salt Lake City, Utah. So I always imagine the blondest, bluest eyed, as white as you can get as the reference here. And this is our Yoruban population that I spoke to. And other subsets they've done all over the world have actually fall either on this line or in between. So these three represent the standard because they're the farthest out in terms of what's called principal component analysis. These are markers on genes that actually give us our race markers. Figure B actually looks at the high-grade cases and the high compared to their controls. And what I was looking for is to see if my green dots as cases were actually closer in polarity or to either their Africanness or their Europeanness compared to the rest of my cases. But as you can see, my dots here in the middle kind of fall right in the middle of those yellow dots, which are the cases. And this is a different way to just analyze it by graph. If I kind of mark the Europeanness as blue and the Africanness as red, you can see that the slopes of these, it's hard to see, but these slopes are about the same and no significant difference in their proportion of African ancestry. And this can make a difference if you're actually really trying to create a genetic model or predictive model. You know how when we sometimes calculate things and they say, well, add 0.5 or multiply by 0.3 for a man, or does it change your risk if you're African American? And this is how some of that data comes into play. So for my study, really this preliminary data, because it's such a small sample set, actually serves as a proof of concept that there's genetic predisposition to high-grade dysplasia in African American women and in HIV-infected women, but more pronounced in HIV-infected women. those odds ratios are really probably just because it's such a small sample size, but the genetic SNP actually really outweighed the clinical history and even some of the concomitant STIs. The other thing that was interesting, so for the SNP that I found that were significant, 10 out of the 12 significant SNP actually have a higher frequency on the HapMap data in European women. So even though my sample set actually had more African Americans, it's actually possible that these SNP would actually remain significant even in a larger cohort that had European women. For the sake of time, I'm going to actually move through these two really quickly. But in terms of looking for, are there any other ways that I can, besides doing HRA, besides doing biopsy, besides doing repeat colposcopies, is there any way that I could either find a biomarker, or maybe can I get some fluid from the cytolite fluid that I do, that's left over and discarded after I do a pap smear, something that's less invasive that can actually tell me if I can find something that predisposes women. We're looking at other ways, maybe even besides blood or besides biopsy, to actually look for microRNA or even DNA in some cases that tends to be a bit more stable, that might point us to a gene or a gene product, a protein, that we may be able to use as a biomarker. And there is some data that actually shows that there are candidate microRNA that can actually be used as a biomarker. The levels go higher as the woman progresses through stages and levels of dysplasia. Lastly, I want to talk to you about a project that we did here through our anal cancer screening program. So if you can recall, Dr. Geiser, who gave grand rounds 2 weeks ago, actually spoke a little bit about the heavy burden of anal dysplasia and anal cancer in our population, and one of the few cancers that actually has been increasing since the advent of really, really good medicines to fight HIV. And more importantly, for people who take care of both HIV negatives and positive, oftentimes people will come to us and complain of either discomfort or rectal bleeding, and no one examines or looks. And we also, I think we often just attribute rectal bleeding to either types of sexual activity or to hemorrhoids, but actually rectal bleeding is actually the most common presenting symptom of anal cancer. And very few actually have a feeling of fullness or a mass. So the risk of anal cancer continues to increase, but even more importantly, what I think is always interesting is that the rates of anal cancer in HIV-infected women actually surpass the rates of cervical cancer that was used as the benchmark of why we need to do annual pap screening in the 50s. So if we use that logic, it's actually quite important that we actually test and screen HIV-infected women for anal cancer. I can't tell you the number of fights I've had with women who have said, "What are you doing? What are you talking about? Nothing goes there." And the way I explain it to patients is that, just like I'm looking for the virus from your cervix or from the vagina, if you think about it, the separation between the two spaces is about the size of the septum on my nose. So it doesn't matter actually type of sexual activity or practices between either just wiping or menstruation. It's possible to actually introduce the virus there. It turns out from the data that Dr. Geiser has actually collected, and actually I tell people around the world, the most common form of birth control actually is receptive anal sex. So if we treat everyone equally, and we don't even need to ask about sex practices. So one big data set that actually came out to look about are there ways that we can prevent anal HPV infection and neoplasm. Actually, Joe Palevsky again, essentially one of the big minds in anal cancer and in HIV, actually used the quadrivalent HPV vaccine in about 600 men who have sex with men, HIV negative, and showed a marked decrease in anal HPV infection and grade and prevalence of AIN. So we actually developed a study, 5298, that's in about year 3 now. We actually wanted to see not just immunogenicity, we actually want to see efficacy, and not in HIV negative men, as Dr. Palevsky did on the previous slide, but in HIV infected men. Then they said, "Michelle, is there anything that you would add?" I was like, "Actually, I would add women. How about women? We have anuses too." But because the disease is so prevalent, I thought it was important to make sure that women were included. So that's actually another Another reason why it's important to have equity, not just in the job, but on study teams and when you're developing studies and trials. If no one's there, no one would think to ask. So this study was actually different because we actually required that everyone have the high resolution endoscopy. Usually that's the test, essentially that's the colposcopy for the anus that you go to after you've picked up something abnormal. We designed the study that everyone had to have the HRA at the beginning of the study, regardless of what their anal pap said. We found that in men, the baseline prevalence of high-grade anal dysplasia was about a third, 33%. We presented this at our big HIV last year. We knew the nonavalent vaccine was coming out. We actually wanted to see the prevalence of all the vaccine types, including the additional 5 in the new vaccine for men and women who had either high-grade lesions or not. And as you can see, it was about 20 to 30%. And in our research unit, out of this 500 and change, we enrolled about 55 participants. And what was interesting to me, we actually had one of the highest prevalence of high gain in women that had ever been recorded. So it's like, actually, it's more prevalent than you think. And it's really because that we were doing these HRAs regardless of the anal pap. We actually found 2 women who had normal anal paps who actually had high-grade lesions. So actually, Dr. Goldstone, who is a surgeon here, had been doing all of these high-resolution endoscopies, and he was calling me about one of the results. And I said, no, pathology said that it's low-grade. And he said, absolutely not. I've been doing this for 10 years. He's like, this is, if it's not cancer, it's high-grade lesion. I want you to go back to pathology and have them run some additional studies. So I looked into what the studies that he was looking at. So there's actually other genes that are associated with proliferation that you can actually stain for. One is a cyclin kinase inhibitor, P16, and Ki67, and this is actually a table looking at the clinical performance of some of these biomarkers, but we were actually able to, we repeated that, actually able to ask pathology to do new cuts and restain. So essentially these were both called low grade. This actually looks a little bit more suspicious. Remember I said that if we see those clearing around nuclei in really dark black, racinoid nuclei, it should be suspicious, but it was actually called as low grade. So we actually did the P16 to actually see if that stained higher up to show any abnormal proliferation. Didn't stain black here, very obvious here. And the proliferation marker, you're supposed to have these columnar cells, the nucleodyne here, that are actually turning over because that's their job. And you can see that this goes full thickness. So this was actually recalled as high-grade lesion, but no microinvasive cancer. But Dr. Goldstone was right, and I learned something. So the review from the data in our clinic, so Dr. Geiser actually created an anal cancer screening program here at Jack Martin about 5 years ago. So it was implemented in 2009, and what we've actually did is that we looked at the screening guidelines that are recommended in New York State for the screening of HIV-infected women. So it actually says that annual anal paps should actually be done in HIV-infected men who have sex with men, HIV-infected women who have actually ever had an abnormal cervical pap or colposcopy, right? And HIV-infected either men or women who have ever had warts. So HPV is there. You have some documentation of HPV disease. We should look better. HIVMA, the HIV Medicine Association of IDSA, in 2013 actually included all 4 of those and then added HIV-infected women with a history of receptive anal intercourse. And I was like, no. So it turns out the president of HIVMA at the time was my boss. So I said, Judy, Dr. Aberg actually writes the guidelines, and I said, well, where did this come from? I've never seen any data. And she said, actually, I don't know. She goes, we turned it in, and then it came back with that recommendation penciled in. So that actually increases the number of screening, but I think it dilutes the message a little bit, right? So the anal cancer screening program here, actually what we do is actually recommend that all of our patients get screened regardless of those guidelines, and then Dr. Geiser performs HRA on anyone who has an abnormal pap. So we expand the criteria who we're looking for, and we actually have the added benefit of all of them being done equally well by the same person. So we looked over the past 5 years. So over the past 5 years, we had 800 plus HIV-infected women who were screened with anal cytology. So we have a provider who does all of our PAPs right there in our clinic. While she's there, she asks or offers anal PAP. People have the right to refuse. We're actually going through the data to see the most common reason, or really the percents that actually refused. Women who actually get sent to our GYN clinic, it turns out that GYN does not do anal PAPs on HIV-infected women regardless of our guidelines, so we're working with them as well. So out of this nearly 900, just under 500 of them actually had abnormal cytology, and just about 300 of them actually underwent high-resolution endoscopy. So out of those 300, about 100 were either found to be benign or just warts, not cancer or mild dysplasia. Another 40% had low-grade dysplasia, and again, just under 30% had high-grade dysplasia, which was comparable to what we had seen in the men. In terms of lowest CD4 count and viral load, the thing that tends to be most striking is really the number who are either former or past smokers. There's been an association with cervical cancer and smoking. But I think this is important too, is that sometimes what you get on PAP really does not correlate at all to whether or not you're going to have a worse lesion there. So do not disregard ASCUS. It turns out that one of our low-grade, not quite sure of the clinical significance of this PAP, consider repeating in 6 months, actually turned out to be our one woman who did have invasive cervical cancer. When we look at anything that may be associated with the development of high-grade lesions, history of anal sex actually kind of almost crosses that line, but smoking was the most significant. But what I thought was most striking, and we presented this at CROI last year, we had an oral presentation, is how many of these high-grade lesions would be missed if we just followed the criteria for screening that we were supposed to. Because Dr. Geis's program screens everyone, we're picking up more people than is recommended. And there would have been 54 women, had we followed the New York State AIDS Institute guidelines, that had high-grade lesions that wouldn't have been picked up. If we follow the HIVMA guidelines, remember the HIVMA guideline just added the history of receptive anal sex, and Dr. Geis collects that data, there still would have been 20 women that were missed. And it turns out that the one woman with cervical cancer, again, was in this section that would have been missed. She wouldn't have been screened at all had we been following the guidelines. All right, so the risk of anal high-grade lesions increased with the degree of cytology, abnormal cytology, but it really wasn't a great correlation, and that's been consistent with other studies. And really an expanded anal cancer screening program, there were still women that would have been missed had we followed the guidelines, and maybe it should be considered that all HIV-infected women should be screened for anal dysplasia. All right, so my last 2 slides, just wrapping up, goes on to actually just review really that HPV, really the HPV E6 and E7 are really the oncoproteins that really make HPV oncogenic, and humoral antibodies that the preventative vaccines induce actually help us clear, actually help us prevent the establishment of true infection, but really cell-mediated immunity is what helps us get rid of established infection, not just prevent it. There's a greater risk and burden in HIV-infected populations, both male and female, and improved screening with actually more anal dysplasia screening is probably warranted. All right, so I wanted to give my acknowledgments to actually all of the team here. I'm not sure if you guys are aware, but even though I was a student here, I've only been back for about 2 years here, and it's really been an incredible group of people to work with and interested people. But really special thanks to my mentor for all these years, Judy, Michael Mullen. Guys that does an incredible amount of work to do HRAs on over 3,000 people all by yourself in 5 years is very impressive. And our residents and fellows who work with us. Some of my team at NYU, the genetics guys at Harvard, because I didn't know anything, but they helped me, and I actually got another master's and did a great bit of work in genetics to finish that study. And really, I think it can't really go without saying all the clinical trial time and the time and effort and poking and prodding that our clinical trial study participants go through. All right, thank you guys. Thanks for